Now we proceed to the next session, the Homi Baba Oration. May I request Professor Elizabeth Binod, Dr. David Phillips to be on stage, and Dr. Kumaravel also to be on stage, to provide us with insights into the life and legacy of Homi Baba. I am delighted to invite Professor Elizabeth Binod, Associate Professor in the Department of Physiology at Christian Medical College, Vellore, to the stage.
I have the honor and privilege to read out and introduce the Homi Baba Memorial Oration. The Homi Baba Memorial Oration stands as a tribute to the indomitable spirit and pioneering vision of Dr. Homi Jehangir Baba, a luminary whose contributions to science have transformed numerous fields including medicine. Dr. Baba is best known as the father of the Indian nuclear program. Baba's early education took place at Bombay's Cathedral and John Kennan School. At the age of 15, he passed the senior Cambridge examination with honors from Elphinstone College. In 1927, he traveled to England to study mechanical engineering at the University of Cambridge, fulfilling his parents' wishes. However, his passion for physics led him to pursue a degree in the subject, and he earned his doctorate in nuclear physics in 1935. During his time at Cambridge, Baba conducted significant research on cosmic rays and quantum theory. His work on electron-positron scattering, later known as the Baba scattering, provided valuable insights into particle interactions. With the outbreak of World War II in 1939, Baba returned to India and joined the Indian Institute of Science in Bangalore, where he collaborated with Nobel laureate C.V. Raman. Recognizing the need for a dedicated research institution in fundamental sciences, he founded the Tata Institute of Fundamental Research in Mumbai in 1945 with the support from the Tata Trust. Baba was instrumental in establishing India's nuclear energy program. In 1948, he became the first chairman of the Atomic Energy Commission of India, overseeing the creation of the Atomic Energy Establishment, Trombay, which was later renamed the Baba Atomic Research Center, BARC, in his honor. He believed in harnessing the power of nuclear for the betterment of human health. Under his leadership, India's atomic energy program became a catalyst for the development of nuclear medicine. This field, which leverages radioactive isotopes for both diagnosis and treatment, owes much to Baba's foresight and commitment to interdisciplinary collaboration. One of his most notable contributions to medicine is the introduction and development of medical isotopes in India. Their applications in nuclear imaging, such as positron emission tomography and single photon emission computed tomography, have revolutionized imaging modalities. By enabling precise visualization of internal physiological processes, these techniques have become critical in the early detection of conditions like cancer, cardiovascular diseases, and neurological disorders. The establishment of premier research institutes such as the Tata Institute of Fundamental Research and the BARC under his guidance was pivotal in advancing medical sciences. BARC in particular played a crucial role in producing medical isotopes on a scale that made them accessible across India. This accessibility ensured that advanced diagnostic and therapeutic tools were not limited to developed nations but were available to patients in India and beyond. Dr. Baba's contribution to cancer treatment stands as a testament to his impact on medicine. His vision inspired collaborations between physicists, biologists, and medical professionals, leading to innovations that bridge the gap between theoretical science and practical healthcare solutions. Let us today honor his memory by continuing interdisciplinary collaborations, ensuring that his legacy endures in the pursuit of a healthier and better world.
Thank you very much, ma'am, for your thoughtful and inspiring words. May I invite Professor Meredith Hawkins on stage. It is my privilege to invite Dr. David Phillips, Professor of Endocrine and Metabolic Programming at the University of Southampton in UK. Dr. Phillips will introduce Professor Meredith Hawkins, the recipient of the Albert Einstein Oration. Homi Baba Oration, sorry.
So we hereby bestow the prestigious Homi Baba Award upon Professor Meredith Hawkins. Dr. Hawkins dedicated her career to advancing knowledge and fostering global collaboration in diabetes research, leaving an enduring impact on both academic scholarship and clinical practice. As Professor of Medicine and Associate Director of the Einstein Mount Sinai Regional Diabetes Research Centre and holder of the Harold and Muriel Block Chair in Medicine, Dr. Hawkins has demonstrated unparalleled commitment to improving diabetes care worldwide. Inspired by extensive experience managing diabetes in resource-limited settings since 1996, she established the Global Diabetes Institute in 2012. Dr. Hawkins' expertise was further recognised through her service on the congressionally appointed National Clinical Care Commission, tasked with optimising diabetes care in the United States. She also serves as a clinical subgroup academic investigator for the NIDDK Working Group of Council, addressing the heterogeneity of diabetes. Dr. Hawkins' innovative research, particularly her insulin clamp studies, has led to groundbreaking insights into the metabolic profile of atypical diabetes. Her influential work on low BMI diabetes in lower socioeconomic populations is regarded as a cornerstone in understanding this underexplored phenotype. Her research has been consistently supported since 1999 by the National Institutes of Health, along with funding from the American Diabetes Association, the Juvenile Diabetes Federation International, and the Diabetes Action Foundation International. In addition to her distinguished academic achievements, Dr. Hawkins is an extraordinary mentor who has shaped the careers of over 100 MD students, residents, endocrinology fellows, and junior faculty members at Einstein Diabetes Research Centre and globally. Many of her mentees have made significant contributions to diabetes research and clinical practice worldwide. With heartfelt gratitude and admiration, we honour Professor Meredith Hawkins for her outstanding contributions to diabetes research, her tireless mentorship, and her profound influence on the individuals and communities she has touched. It is with great honour that we bestow upon her the prestigious Homi Baba Oration Award on this, the 11th day of January 2025. We celebrate her enduring legacy and look forward to the continued impact of her work and leadership for years to come.
Thank you, Dr. David Phillips, for the excellent introduction. As a token of our gratitude and respect, I now invite Dr. Kumaravil, Chief Endocrinologist and Director of Alpha Hospital and Research Center, to present the ceremonial shawls and plaques to Professor Meredith Hawkins. my great honor to invite Professor Meredith Hawkins to deliver the oration. We eagerly look forward to hearing her inspiring words and valuable insights.
A very deep and heartfelt thank you to the organizing committee for this tremendous honor. Thank you. This is something that I could not have even imagined back in November of 2008 when I made my first visit to the august Christian Medical College and remembering the incredible legacy of Ida Scudder and believing fervently that by coming here, somehow we might be able to work together to do some novel investigations in diabetes. But little could I have dreamt all that would have transpired between then and now, and that I would be standing here with you all. So thank you, very truly. Now, so this then, the topic of today would be the physiology of something that goes by many names, and we're going to explore a couple of those names today. But this is a global conundrum that I'm going to present to you today, and I'm going to explore with you the physiology of something which we might variously call various things, but we're going to start out by referring to it by the name atypical lean diabetes. Now, Mahatma Gandhi once said that when we're pondering what we should be doing, wherever we're at a crossroads in our life, and whenever we're to be making any decision that might impact the future of what we do, he said, at those moments, think of the face of the poorest person that you can remember. And as you contemplate that person, and you contemplate the sufferings and challenges of that individual, use that as your inspiration for your next step. And so for me, it's very simple. The person who comes to mind immediately is an orphan named Isaac. Other benefits of diabetes management. Isaac will therefore always stay on in my mind as someone of such tremendous need, but also of someone who presented a bit of a conundrum even then. And so at the time I was intrigued, what form of diabetes could Isaac have had that would allow him to not go into diabetic ketoacidosis during long periods of time off of insulin? We're going to start to put Isaac into context now, into a much bigger global context. And of course, this meeting itself presents an enormous global context. And we've heard so eloquently from so many others that we are, of course, facing this incredible pandemic. And of course, the global numbers and the global increases are probably an underestimate we're now realizing. But the two areas at the bottom of the slide are those that we've been speaking about quite a bit during this meeting. The regions of Africa, so we're talking sub-Saharan Africa, as well as Southeast Asia, so well represented here. And the fact is then that in those regions, we are facing, as we have heard, incredible heterogeneity of diabetes, different forms that are really unknown or not encountered in high-income countries, and yet that are increasing rapidly at great proportions. And therefore, it behooves us to begin to comprehend and to try to grapple with some of these issues of what forms of diabetes are in fact on the rise in these places. And looking at Isaac as an N of one, what can Isaac and his form of diabetes teach us about what could be prevalent the world over? Now, here enters a certain term. I've mentioned to you that the topic of my oration today is going to be a form of diabetes that has gone under many different names, and this will be one of many. The interesting thing historically is that going back to 1907, there were reports coming from Sri Lanka that there were many individuals with diabetes who were observed to be grossly underweight, but felt not to have the type of diabetes that required insulin for survival. And then in 1955, probably got even more publicity because of the Lancet paper coming out of Jamaica, giving it therefore the name J-type diabetes. And it was intriguing that it was based on 13 cases, which were in an academic medical center, the same one which has been well represented here at this meeting by Dr. Thompson and Dr. Boyd. In any event, at this medical school, diabetes clinic, it was noted that there were 13 patients that did not fit what were believed to be the criteria for either type 1 or type 2 diabetes. It took a very astute clinician, Hugh Jones. It is intriguing when you think of just 13 patients that made him intrigued to think that there was something other than those two, at that point, what was believed to be only two forms of diabetes. And it was that report coming out of Jamaica that really first intrigued the world that there was something else. And this was followed by other reports, and I'm just going to name one, but there was a subsequent one mentioning more of the pancreatic form, but still a malnutrition-related entity. Report soon followed from Indonesia. There were many other reports that followed between 1959 and 1985. A lot of them came from this subcontinent, and this ultimately resulted in the World Health Organization recognizing this entity and naming it malnutrition-related diabetes. Soon thereafter, modified to malnutrition-modulated diabetes. But in 1999, a further classification, the current one, in fact, that was written by the WHO, removed this particular classification, citing a lack of evidence proving that malnutrition per se caused diabetes. And yet one might ponder, truly, if one had kept the name malnutrition modulated or even malnutrition associated, could we perhaps have hung on to that? So I'm going to challenge you with that. And I'm going to actually begin by giving you a few of the characteristics that had been reported to give you a picture of this type of diabetes as it was thus called, and allow you to think of whether or not Isaac might have fit in that category. Now, these individuals developed diabetes at early onset, quite young, generally under 30 years of age. They were lean. We've talked about BMIs, and these were certainly people who had BMIs that were under 19 and often quite a bit under 19. And what was often noted was the combination of the fact that there had been poor nutrition in utero or early childhood, but the fact that that continued to the time of diagnosis in teenage years or in early adulthood, that this had been a persistent pattern of undernutrition for a long period of time. Now, the case reports that were described all noted that this was severe diabetes, and severity really was described by the degree of hyperglycemia of these individuals. So frequently they were described to have high fasting plasma glucose levels, for instance, over 250 milligram per deciliter. These were very often, or nearly always, seen and diagnosed in rural settings. It would be a small rural clinic. An individual would come in, and if they were fortunate enough to have someone check their blood glucose and not just dismiss them as having malaria or some other tropical entity, but if someone actually measured their glucose and then attempted to start them on insulin, it was noted that they tended to have high insulin requirements. But, like Isaac, they were resistant to ketosis, even when they went without insulin for periods of time. You'll notice at the bottom of the slide that so many of the reports that have been put into literature have come out of India. And it was really motivated by that. Having seen patients like Isaac in Africa, it motivated me to come here to India, and it was drawn very much to Christian Medical College based on its incredible legacy, but motivated to want to try to understand better what could underlie this intriguing form of diabetes. And given that the World Health Organization had withdrawn the classification based on lack of evidence and lack of research, this came to me then as a great challenge. Could we not then put our heads together? Could we not then come to a place like Christian Medical College in Vellore, where we could have a combination of the possibility of finding individuals of low BMI and diabetes, but also to be able to apply rigorous research methods to be able to delve deeply into the physiology of this condition and to be able to present to the world and the World Health Organization, among others, present the evidence that was up until then lacking. Now, I'll show you something intriguing on this slide. The fact that the glucose levels were high, and therefore when these people were put on insulin, they tend to be put on a lot of insulin. Now, that led everyone in general to believe that this was an insulin-resistant entity. And that led me to think, as I witnessed children in Africa dying when they were put on insulin, saw them dying even on small amounts of insulin, dying of hypoglycemia, it made me question, were they truly insulin resistant, or was it the fact that when they were placed on insulin, they were off in rural areas, they had very high glucose levels, and so the physicians, when they were first treating them, would therefore be motivated to give them large amounts of insulin? Was it therefore basically a pragmatic clinical phenomenon of giving people insulin as opposed to a true underlying physiologic problem of insulin resistance? That could be monumentally important, of course, because if these individuals didn't require insulin for treatment, if they could be managed with much safer oral hypoglycemic agents, this could preserve life in these young people. And this is another individual, Ponciano. A similar scenario of also, in this case, he was the son of a widow. She wasn't able to afford transportation to get him to hospital. So for 2 years, Ponciano had had symptoms of polyuria, polydipsia. And yet, when he presented to a little rural clinic, he was very hyperglycemic. His glucose was over 500, but he did not have ketoacidosis. Where are these cases? Where have they been reported? And I'll show you then. The stars all represent where cases have been reported of this entity. And the fact that there's only one country in South America, that being Brazil, where it's been actually reported, suggests that perhaps it hasn't been studied as extensively as it might be. But you can certainly see a sense here of a tropical distribution, and you can certainly also see that there have been many reports of this on this subcontinent. Now, and you'll also see, of course, the overlap between undernutrition and the regions of the world. Not surprisingly, you would see then this overlap between the prevalence of undernutrition and the appearance of this entity. So one might ask, what could lead to this, to the pathophysiology of this low BMI diabetes? I've used yet another term. As you can see, and I'll explain to you in a little bit, it's problematic when a name gets withdrawn, because what do you then call it? And so we've tended to go, up until now, we've tended to go with a very generic sounding name, lean diabetes, low BMI diabetes, atypical low BMI diabetes, because of the fact that we're not able to rely upon an official name to designate this entity. But what might, in fact, lead to this entity, you might ask? How could very thin people who did not have an autoimmune form of diabetes, how, in fact, could they develop diabetes? Was it predominantly an insulin-resistant phenomenon? And if it were, then our hypothesis was it could, in fact, be a functional form of lipodystrophy. It might, in fact, be that these individuals had such a reduced fat mass that there would be very little place in the body to store any triglyceride. So any intake of triglyceride would find its way to tissues such as the liver, where it could give rise to insulin resistance. Or, on the flip side, could this be predominantly an entity of decreased insulin secretion? The reason why we were questioning that was because of the known importance of nutrients and nutritional deprivation on the development of the beta cell. And so it gave us reason to wonder whether perhaps the early life deprivation and that continuing deprivation into adulthood could have resulted in decreased mass and function of the beta cell, leading to a defect in insulin secretion. And so the goals then, as I came here to Christian Medical College, as we founded this partnership, the idea then was to define the metabolic phenotype as well as whole body glucose handling in low BMI individuals who met that WHO classification of MRDM, and using gold standard techniques, which included, and I'm going to elaborate a little bit more about them, but including stepped insulin clamp studies. studies of insulin secretion using C-peptide deconvolution, and then sophisticated anthropometric measures. And why CMC Vellore? The fact was that this was a very unique place in which this sophisticated methodology was possible, and I would give thanks to our Copenhagen colleagues, Dr. Vo and his team, who had been here ahead of us and who had actually already set up sophisticated clamp studies. That was a wonderful legacy upon which we could build. And as you can see, the 3 Tesla MRI, into which we would then be able to study our subjects and be able to carefully define the fat depots, etc. And then, of course, the intelligent, dedicated, highly motivated individuals, such as our Dr. Aaron, as you'll see at his graduation. We continue to be so impressed with the level of dedication, the innovation, the dedication, the motivation that has allowed this very overly ambitious venture to take place and to be able to bring it to fruition over the course of about 10 years. So in embarking upon these studies, in order to find inclusion criteria for this low BMI diabetes, it ultimately really meant that we were also excluding all known forms of diabetes, thinking back to that whole differential diagnosis. We had to exclude, of course, anyone that had other known forms of diabetes in order to be able to be certain that we were describing this actual neglected entity that had been previously known as malnutrition-related diabetes. So these people had to be very lean. We were looking for people with BMI under 19. That took us out to rural areas, often more than 3 hours outside of Vellore, often into these very rural areas, small rural clinics, where we were able to find people who met that description. And we were very rigorous in making sure that all of these criteria were met. These individuals had no history of ketoacidosis. They had no pancreatic pathology on imaging, so this was not FCPD. They were antibody negative. They did have a preserved C-peptide response, so when we did a standard mixed meal test, we were rigorous about excluding type 1 diabetes. We ensured that they had a minimal C-peptide response. We ruled out family history of diabetes. We also ruled out complications because of the rigor of the studies that we were going to undertake in these people. And we also ruled out, thanks to Aaron and his team, we ruled out all known forms of MODY as well as all known lipodystrophy genes. And so based upon this then, we were quite confident that we were looking at a form of diabetes that was not going to fall under any of the known categories. And these were our groups. In addition to the group shown in orange, our low BMI group, we wanted to study them in comparison with known forms of diabetes, specifically type 2 and type 1. And then because we needed controls that were matched by BMI, we had 2 control groups of non-diabetic subjects, one who were lean, matched to the low BMI group, and then another group that was considered overweight, who were BMI matched to the type 2 diabetes group. When you look along that orange line at the top, you're going to notice that in addition to being lean, that they had poor glycemic control, that it was actually considerably worse than the other 2 groups with diabetes. And so because it was so important that this would not influence the results of our clamp studies, we had to very carefully manage their diabetes before the studies so that we could actually maintain neutrality of glucose levels by the time of the clamp study. There's a reason why this is so important. For all of you that are familiar with the concept of glucose toxicity, the concept that high glucose levels themselves will cause both insulin resistance as well as defective insulin secretion meant that in these individuals coming in with very high glucose levels, we had to first correct that glucose toxicity before we could make any conclusions about their insulin sensitivity or secretion. So that involved, as you'll see here, intensification of therapeutic regimens for 2 weeks. This was undertaken by our colleagues at CMC, who worked carefully every day with these individuals to bring down their glucose levels. And then the day before the study, they came in to the diabetes unit. They actually received insulin infusions for 18 hours that slowly brought down their glucose levels further, so that all individuals with diabetes were studied under euglycemic conditions. So we very carefully and rigorously removed glucose toxicity completely from the picture and wanted to see whether that would make an impact in terms of those earlier case reports. So this is exactly the type of study that we performed. I'm going to no pun intended, I'm going to step you through the slide, which is rather complex. At the top, you'll see that in order to maintain fixed insulin levels in all subjects and be able to do that during a 6-hour study, we had to have control over their endogenous insulin secretion. So we infused somatostatin. We inhibited all endogenous insulin secretion, and we had to replace back growth hormone and glucagon that were also inhibited. We used a stable isotope tracer, which we used in order to be able to measure glucose uptake into tissues and as well as glucose production. And we also, in the later parts of the study, infused glucose as required to keep them completely euglycemic. The important part of the slide is down at the bottom, the blue arrows. You'll see that the 6-hour study was divided into 3 2-hour increments. The first was the basal phase, and that was where we determined in each individual subject what their exact basal insulin requirements were. That required a lot of adjustment of the insulin infusion rates to keep them just at 90. We kept them euglycemic. And once we had determined exactly what their individualized requirements were, we then embarked upon the second phase of the study, which was designed to look specifically at the liver and how insulin sensitive the liver was. And so we increased, by one step, we increased the infusion rate of insulin to attain moderate levels of insulin, not enough to completely suppress hepatic glucose production, because we needed to look specifically at how sensitive that liver was to insulin. We then wanted to know how sensitive the rest of the body was to insulin, skeletal muscle, adipose tissue. So we embarked upon the final step of the study, which was the high insulin phase, where we raised insulin by a much greater step in order to maximally stimulate glucose uptake into the whole body. And as noted through the whole study, they were maintained rigorously at 90 milligram per deciliter. I continue to have incredible awe for our colleagues at CMC for the caliber of the clamps that they performed. They were world class, I can only say. It would be, yes. Bravo for what was accomplished. And so now the results. We're going to start with the liver. Because of the fact that, of course, the liver is such a factory for producing glucose, we know the importance of the liver for determining fasting glucose levels. What we're looking at in this slide is endogenous glucose production. So the glucose that was being produced by the liver under these intermediate insulin levels. I'm going to walk you through the slide and show you that it was actually the green group that were the lean, non-diabetic control group. This would be to show you what a response to that intermediate insulin should look like. So there should be a nice suppression of glucose production, and there was. I'm going to compare that with the group in the middle. The group with the black triangles was the group with type 2 diabetes. And you'll see that there was heterogeneity there, but you'll see that on average, these individuals were really quite insulin resistant at the level of their liver, meaning that they did not suppress glucose production at those same insulin levels. Looking at their visceral adipose tissue as well as their hepatocellular lipid. And this was, of course, of great interest to us because of that question, were they spilling lipid into other tissues? And so what I'm going to show you, as always, the comparison group, the green group there, showing very low visceral adipose tissue, showing very low hepatocellular lipid on the right. By comparison, the black triangles, the individuals with type 2 diabetes, you'll see there's a range, but you'll see that their visceral adipose tissue is much higher, as was their hepatocellular lipid. Type 1, low. But then we'll look on the far left at the low BMI diabetes group. And there was a little bit of heterogeneity. The very first individual that we placed in the magnet did have high levels of intrahepatic fat. So one individual did. But on average, they did not significantly differ from the non-diabetic subjects in terms of hepatocellular lipid on the right or in terms of visceral adipose tissue on the left. This is actually very important because there have been many individuals described in many studies as lean. And of course, technically speaking, we could say that anyone with a BMI of under 25 was lean, depending on how we define the word. But the bottom line is that studies that have looked at people with BMIs between about 21 and 23 have seen something quite different from this. They have tended to see that even at what we would consider to be quite low BMIs, this would be in an Indian population, even at BMIs between 21 and 23, there still would be visceral adipose tissue, still quite measurable increase above non-diabetic levels, and similarly increases in hepatocellular lipid. So this indicated to us that we were dealing with, at those levels of BMI, we were dealing with something that was distinct from other, quote, lean diabetes that had been previously reported. And I'll just skip very quickly over this just to indicate that they also had low truncal fat mass compared to the other, comparable to the other groups, but definitely much lower than the type 2, and also within the muscle, both IMCL and EMCL lipid also was low. So that gets us back to this question. How could we answer that based on the studies that we've performed? Well, that completely debunked the question that these people had insulin resistance. They did not. Moreover, with one exception, we did not see tissue triglyceride accumulation. And so then that led us then, given those insulin secretion curves that I showed you, that highlighted the fact that this appeared to be a phenotype that was marked by marked defect in insulin secretion. So we conclude by saying this is the first study to use carefully controlled conditions to study, however we might wish to call it, atypical low BMI diabetes. These patients have markedly decreased insulin secretion, but overall no significant insulin resistance, suggesting that this entity is a distinct entity and deserves its own classification. Thus we wrote in 2022. So it did have a classification, as I pointed out. This is what the World Health Organization list looked like in 1985. There it was. This is what the World Health Organization classification looks like in 2019. There's a broad category for unclassified diabetes. And this leads to the question, what's in a name? Surely that which we call a rose by any other name would smell as sweet. Well, not having a name is a problem. Not having a name is a problem because in terms of trying to get grants to research this, not having a name is a problem because it's not going to have a place to put it into a textbook. Not having a name is a problem because you don't have a place to list it in a World Health Organization classification. And that has been what has happened the last 25 years. There have been people, there are heroes in this room who have been studying this entity in far corners of the world and demonstrating that yes, indeed, this entity is present in large numbers, probably millions of individuals. And yet, when I go to lecture in various places, I'm asked, how is it that we could be seeing so many of these patients and yet we've never read about it in our textbooks? How have we never heard of this before? And I say, where are your textbooks written? Inevitably in the West. And so this is now really now a moment of saying we have to be contributing more to the textbooks. I'm thankful that, in fact, our colleagues here at CMC are actually writing textbooks. But the bottom line establish better the physiology. And I give enormous thanks in a recent meeting that we had among people who actually had studied this carefully on the ground and had carefully delved into this particular form of diabetes. I give great thanks to Dr. Peter Schwartz for his call to action, for saying that this deserves a name, and among possible names, why not type 5 diabetes? You heard it here first. Ultimately, I will conclude by underscoring the reason why ultimately we need a better classification, why we need more research, is because this has enormous implications for treatment of this condition. Because, of course, so frequently, if this is a non-autoimmune diabetes, we would be telling them to lose weight, but this could be detrimental for low BMI people. Metformin may in fact be a treatment, and in fact I've been hearing some good anecdotal stories about using metformin, although it will not address, of course, that severe defect in insulin secretion. Agents that precipitate hypoglycemia are dangerous in the face of food insecurity. Any of those of us that have dealt with treating these individuals have known the tragedy of insulin-induced hypoglycemia, deaths and coma. This is a very significant issue. On the flip side, procuring and storing insulin is so problematic in so many low and middle income settings where this entity occurs. There would be questions about diets, because these people usually would have meager and high carbohydrate diets. So more research is urgently needed, and developing appropriate treatment strategies is critical. And I would like to dedicate this talk in memoriam to my mother, Barbara, who died a week ago, and who dedicated her life to various causes that helped the least of these, just as all of you are dedicating your lives to such people, to the vulnerable. I applaud all of you. And I also wish to applaud the many, many people, many of them who are here in this room. But you can only imagine how much effort was required to locate and study with such rigorous methods, and then analyze the data, and then publish the paper, and then disseminate this around the world. The work that has gone into this has been monumental, and I thank you all so much for all that you've done to make this possible. And thank you for listening.
As a gesture of our profound respect and admiration for the invaluable contributions, I now invite each of you to rise and join me in extending a heartfelt standing ovation to honor Professor Meredith Hawkins.